The structure of any talk that I give usually is that here you'll see, if some people in the back might not, but you'll see what's next. Here is today, and up there it will appear the part of the talk, and there it will appear something about this general slide. So you doze off and you look at here, then I will know you want me to move on. If I see your eyes going between there and there, and you're not looking at the middle, then I know I failed in the middle of the, of the main. But it doesn't matter. This is the right way of trying to use PowerPoint, which is very damning to science. But I'm not going to do a TED talk of 25 minutes. I'm going to use the PowerPoint in a meaningful way to convey information for those who cannot tweak into my accent. Okay? But if you cannot tweak into my accent, I can do a French accent, or I can do an Italian accent, okay? But I'll keep my Argentinian one. I can't avoid it, okay? So effectively, what happens is for years and years, the way medicine has used the information about the body and behavior is being personalized for thousands of years. So the doctor, or the witch doctor, whoever, knew every patient. Then, after the 50s and more, it started to become massive. So there was the dissociation between the patients and the doctors. The doctors might know about the patients or have a sort of faint recollection of seeing the patients some time ago, but they've seen 100 patients that week, and then look at the clinical history, and they run it like a statistical casuistic thing in their minds to treat them. But now we're going back with all the fancy aspects of the second wave of human genome projects and proteome projects and all of the wide projects, also the wide brain projects from Europe and US. We're going back into this idea that we can get something out of the patient or the individual in a specifics. So you can start to know the person in detail, not because you know the person for years and years, but because you have a ridiculous amount of information, which goes, of course, what they were saying before, the problem of big data, but at the single subject level. So in a way, we have to devise a conceptual framework and a statistical framework to compress the problem of the big data even at the single subject level, when you have all the genome and brain activity for 30 days. For whatever reason, we need to learn to compress that. So today I'm not going to talk about that. I'm going to try to talk about nuggets of examples that we can get to know something of the future of the person, whether they're going to stop responding if they're getting sedated, whether they're going to recover if they have traumatic brain injury. So just a couple of wide, big examples, but at the single subject level. So that's the plan of the main point of the talk. So yeah, this is what I said about development of personalized medicine. What I think is important, and I can tell you a bit more about this. This is the so I'll give you the talk, so everybody can have it, because there's a lot of things, links and explanations in a more obvious way and not so brain broken like me in the border of the talk. So these guys have been trying to claim the idea that for these X amount of years we've been trying to be closer to the patients or know about the patients, and with the started to understand about DNA and getting into the illnesses and the development of the future into personalized medicine, to knowing about the patient, and the cost going down for EEG and NIRS, but also on genome analysis at the single subject level. It used to be almost $1 million at the beginning of the human brain project, human genome projects, and now it's 200 pounds. You can get sort of a wide genome mapping, and it's going to go down and down and down with the new techniques. So in a way, if we know how to interpret this data, the genome data, and for example, brain markers of data, EEG, of NIRS, if we start to compress that, we'll be able to do this online as we speak, to get information about the person, not only about illnesses, but in general about well-being. And that's all very nice. An example that I usually like very much is the idea of percentage of patients whose tumors were driven by certain genetic mutations that could be targeted for specific drugs by types of cancer. So this is for a genetic profile of the person, a particular drug that is more effective than other drugs. Okay? This is a very good example. Cancer is an excellent example about drug targeting. And you can see, but it's not about cancer, but it depends on which cancer. If it's melanoma, it's great because it's absolutely fantastic. Because if you get melanoma and they have your genetic, they map your genetic profile, you're much more likely to get the right, more effective type of treatment than if you have ovarian cancer. So people, before knowing this thing, people used to die more, and now they live more, but also they live better. Yeah, to be brutal in that respect. So the EEG, and I may just a quick overlook about EEG. I don't think I need to talk a lot about EEG, but you put some metal touching your scalp, not your skull, and connects to an amplifier, and the amplifier tries to make that brain activity that is allegedly going inside your head bigger, and then project it into a screen. And this guy, Hans Berger, found this a few years back. Specifically, that year he published it, and from the last almost 100 years, the EEG remained almost the same, looking at wiggly lines and interpreted as you would, just do eye pattern recognition, and we got really good at it. So in the hospitals around the world, when the eye pattern recognition, experts, the doctors or the technicians who look at the EEG in raw as you speak, as you see it online, and then later revise it, they make inference about the patients and help in diagnosis, prognosis, etc. So they write a report the same way the radiographer writes a report about what they see in the MRI or on the CT scan. They write a report and send it to the treating neurologist or the treating physician. And they tell them, I see this, which is a bit funny, and I see that, which is not great. When I see that it looks normal, and et cetera, et cetera. So they do a clinical interpretation based on statistics, that they've seen and the books they've read. But very rarely in clinical settings you have a statistical objective measure of these things. That doesn't mean it's better, the statistical objective measure. It's only better if we train it to be better. So that's what we're doing. We're trying to use fancy mathematics and the conceptual frameworks of cognitive neuroscience that it has developed the last 20 years into that setting of brain activity and EEG. So you can then, instead of doing a few electrodes, you can then do 100 and something electrodes, and then get the power spectrum, and then put the plot, look at connectivity, and do graph theory and funky stuff that I'll explain later. But that gives you slightly more power than looking at the EEG, just that. Okay? It used to be the same way in genome. They used to get the ACTG genome code and literally by eye scan to see if they could see a right type of codon. But that changed very quickly. What we have to do the same in EEG. We have to stop looking at the EEG in raw as the main aspect of trying to know what's going on at the brain level in the person, and looking at fancy measures on top. But the key thing is which are the good fancy measures. So I'm gonna present very quickly just to make a point about the study that Valdas has done in the lab, and now it's in bioRxiv, and it's for everyone to take a look and see and comment, and it's in the process of battling some journals, as it usually happens. But we don't care because it's pre-published, and we consider it published. But I don't care that much because I'm the PI. Valdas cares a lot, and I respect that, and I push him to get the paper out. The very strong details are not important. What is important is I'm going to tell you a bit more about the motor actions in experiments. This idea is that you can have behavioral signatures of things. So this experiment is people were getting drowsy, okay? Just EEG in a chest long, like that, with a button press, with a button box, and they have to say whether they felt a hand twitch. And we were doing TMS, the transcranial magnetic stimulation, and you do a pulse, poof, and if you do a strong pulse, the hand moves, and then you have to say, yeah, it moved, okay? But sometimes you hear the click, and the hand, didn't move. So the pulse was not so strong. Actually, in 95% of the cases, or 90%, the muscle moved, and we measured the muscle, but you did not feel it. Hence, you pressed the button. Oh no, it wasn't there. That's in a nutshell the experiment. That's why I said the information will be in your emails if Vicky sends it, because there's a lot more than I can say in 25 minutes. A beautiful figure of the paper from Valdas is the one that you put the this is a person and this is the brain, as you can see. And you have the TMS and you pulse it, and the information goes to the muscle, moves the muscle, and the sensory information comes back that you felt, goes back to the muscle, comes back from the sensory to the sensory cortex. Somehow, there is some cortical and thalamocortical integration of the sensory area, and then it got transferred some sort of decision making. Oh yes, yes, I felt it or I didn't feel it. And it goes back and you press the button. So this is, and along the way that we took several measures that I'm only going to say something about the motor aspect of this. So it's been a while now that we take behavior at the single subject level as a good thing, as a way to know how the subject in the experiment is behaving, okay? Even if the people tend to put everyone in the same box and say, these 20 people all behave the same more in this condition and that condition, we do have a lot of reaction times and subtleties detected, not detected in each person. So for example, in awake and drowsy, the median response times of saying whether you felt it or not are for each subject most of the time a bit like that. And this is the individual delta between median response times for each person. So you can see here the variability, okay? Nobody is preventing us from doing this at the brain level, right? If we get the right measures, we can get the same attitude we have towards behavior, measuring for each subject what's the difference between one condition and another, or one moment of 8 months and then 12 months in the baby. It doesn't matter. So when we cannot measure behavior so easily and we measure brain, we call that brain signature instead of behavioral signatures. This is where we are. We want to get brain activity as if it was behavior, and then we call it brain behavior. People say, well, you're destroying the black box. Yes, sir. That's exactly the point. The point is we cannot care about behavior if we assume brain behavior is telling us something that is important enough for our hypothesis. That it could be related, in case of patients, could be related to diagnosis or prognosis or treatment, but also could be in terms of prevention in the case of the African projects, because that's what you want in the end. So there's more about this variability. This variability, how as long as you get more and more drowsy, how the median response times change in each subject. And the level of detection. So in this paper, Valdas, I think it basically pushes this boundary of the single subject, more and more. And just a little peek of this, if you do the TMS and you get the brain activity, you can characterize also the brain activity amplitude in each subject between very very awake and fairly drowsy. This is as you go. So you can see here how the brain activity is changing as you get drowsy. The same way we're doing with response time, but now at the brain level. I'm not trying to claim anything that this is predictive of anything later in life about this person or nothing in this detail. I'm just saying we can treat it the same way, okay? And it can be as informative depending on the hypothesis we have. Sorry that I destroyed your paper, and the beautiful conclusions. I just wanted to use it as an example to translate to behavior to brain. This has been done also in TMS and EEG, but with patients with vegetative state, minimally conscious patients. Those are in principle comatose and they start to get better. Again, they do the same. The TMS, creates electrical current. We can measure that. And what is interesting is that you can then get, and this is an important bit. This has been a couple of papers from the Italian group, from Massimini, and Rosanova and Casali have been working with Massimini and Tononi for a while. And this is if you're a vegetative state, and this measure it's like a compressibility measure. You do TMS, you get the EEG brainwave. You take the EEG brainwave and you literally put it in the zip file. You compress that as if it was a JPEG, like you compress it. And how much you compress it is how difficult and complex it is. It is very complicated. It's a very complicated figure. You take a picture of the rainforest. There's a lot of things there, and you cannot compress that figure that much when you zip it. But if you go to the desert and you have like white sun and a blue sky, that's almost very little information. It's beautiful, but it's beautiful in simplicity. When you compress that with zip file, compresses more. The same thing with the brainwave. If the brainwave is like that, you compress it very quickly. But if the brainwave is complicated, you cannot compress it much. So this is a compressibility measure. And that compressibility measure is surprisingly high, that you cannot compress too much, when the person is almost recovered. Here, these three guys are almost recovered. And this what says, so, these guys who are effectively quite bad, but better than the vegetative state, are slightly higher. These are the minimally conscious. They're like a travesti in consciousness, transvestite, so it's sort of sometimes conscious, sometimes not conscious. And these are the allegedly unconscious, the vegetative state. So this is like a measure at the single subject level of 150 trials of and then compressing that, okay? What does it tell us about how the brain works? Not so sure. What does it tell us about what's the, where the patient is? It tells us a lot. And also it has a lot of power in terms of prediction of whether the patient is going to recover or not. It's been a while since the people who are in coma in the hospital, in the ICU, or in the neurocritical care, they get like a classic EEG, and then they look at ERPs. They do the beep, boop, beep, 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 boop, beep, 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 boop, beep, 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 boop, classic oddball mismatch experiment. And they say, well, the person cannot really hear, etc. It's in coma. Well, let's do it anyway. They've done this in the late 70s and 80s and 90s, and now there's a lovely meta-analysis that you can do, and you can see the mismatch negativity, this sort of funny wave, fairly automatic, and the P300, this slightly later wave, post-automatic, not so clear if it's so automatic at the cognitive level. Both of them are fairly predictive of what's going on with this patient. So the mismatch and the P3 appear to be reliable predictors of awakening. This is a wide aspect. Now, that reliability, it's how much is really reliable in terms of single subjects. So we did this with a French researcher that came to us for a year or so, and with Shrivas, and David Menon from the neurocritical care here. And we took patients who were in the first day after the injury, exactly when they take out the sedation. So a patient gets a road traffic accident, they take it, they stabilize it, and when they try to stabilize it, they put sedation in the guy, boom, and they knock it down so it doesn't it doesn't move and pull out the cable, etc. So basically they sedate and to stabilize it physiologically, and then they take out the sedation usually after 1 day or 2 days, and they see what happens. And when you take the sedation, the patient is in principle in a stable state, critical, in a stable state, but not much drug in the system. It's as if you're restarting a computer that fell on the floor. And once you think it's now stable in how it's working, then you see what's going on. And it could be that it doesn't boot, or could be that it doesn't work very well. So what happens when you measure the behavior in these guys when they are in coma? Well, you cannot measure much behavior, just a few reflexes, so it's not very informative. So if you measure behavior after the outcome, either they recover or not recover, it's not very predictive, the behavior when they were in the ICU versus the behavior 1 or 2 weeks afterwards. It just basically doesn't help. But a particular type of mismatch auditory experiment we did was much more interesting in that respect. It was surprisingly much more, much stronger statistically at the single subject level than any of the other studies. And this is because we did something funky with the type of sound, and we do a transfer between one sound and the other. So we got geeky cognitive neuroscience-wise, and that created a very strong effect for the brain of these patients that we can with a beautiful separation between those who had an unfavorable outcome and the favorable outcome of these global field power scores, etc. This is personalized, specifically personalized 15 minutes EEG task on these guys. And the beauty of these things is that we did this analysis, but we knew nothing about the guys afterwards. We knew nothing. So we learned afterwards. Actually, one of these famous patients is the Costa Coffee patient. So we did the experiment, and we forgot about them, and then they were being followed by the clinicians. And we were with Shrivas having a coffee in the hospital in Addenbrooke's, and then she was, a guy in a wheelchair in the hospital. Oh, that's the patient. Which patient, man? The patient that has the best, brain activity. Oh, is it? So suddenly we had a guy, the best guy, was literally asking for a coffee in the wheelchair, which was fantastic, because it was the guy who the doctors were discussing, well, I don't know if he's going to make it, this is not looking good. And we went running the day we did the experiment, we went running back to David Menon and the others, saying, this guy has the most awesome brain activity to the paradigm we ever seen. Don't stop discussing whether what you're going to do, how to tell the family is not going to survive. Stop telling that. We don't care about any of the others. This is the best. This brain activity is better than mine, but better than normal people. So yeah, I mean, this is just just a story, but for us was personally very important. And then when we went back and presented all the data to the clinicians came back telling us this is the outcome of the patients. We had the beautiful split. So yet again, instead of doing normal linear ERPs, they can get very fancy, you can actually take all the information in all the electrodes and do funky connectivity measures. So you're trying to extract as much information as possible and then compress that in what is called, using what is called graph theory, to see what's the most effective path between 2 points. So for example, you have 128 points, networks all over the place, and then you say, okay, this guy is a hub, because this electrode is a hub, because between this connectivity network and that one, they have to go through that hub. So they must be important at the network level. And it's important in mathematical theory, network level, this is an important thing. But in the brain seems to be the same, that you measure the hubness, and the hubness at the brain activity level and the connectivity, the hubness predicts a lot of things. Effectively predicts your capacity to integrate information. So using a bit of hubness in what we call small worldness, slightly relationship between how cluster is the thing and how wide is the thing. So like a beautiful mathematical sweet point of connectivity. We measured that small worldness, and when the people were getting sedated, normal volunteers, any of you, normal volunteers who come and we put some propofol, the most common sedative drug in the world, and you get drowsy, and maybe depending on the variability of the person, you stop responding. The button box that we said, classify these words in animals and non-animals, or living, non-living, or whatever, simple decision. If you stop, those of you who were with the same amount of target level drug, you stop responding, these were what we call the drowsy, because if we poked you, you would wake up and continue responding. But for the amount of capacity of responding you had when the drug we gave you, you stopped responding. You were at the limit. And then others were the fighters, who kept on responding. Not me. I go down immediately. If you give me the opportunity to stop responding, but this is alcohol for 20 years and bad sleeping and etc. a different discussion. But the beautiful of this is that with this funky network stuff, we could differentiate those who were responsive and those who were unresponsive. So that's a bit dumb if you do it when you're unresponsive or responsive, because brain networks by eye, the brain activity, whether you're responsive or unresponsive, you could tell me by looking at both. You said, oh, this is different from that. The beauty of this is we predicted this before they got the drug. So we look at the brain activity in the resting state before even getting the drug, and we measure the connectivity, and we said this connectivity is low or this connectivity is high in this funky hubness thing, and then you're likely to fall down if we give you a drug, and you're very unlikely to fall down. And yet again, the anesthetists, when we told them this, they went bonkers. They said, oh, we're going to throw you money at this, to make it a real thing. Because if it's true that you can predict by brain EEG 7 minutes, resting state EEG, who's going to need more drug to get sedated, or to whom we can give less drug to interact? Let's say you have a guy who's 75 to have his third heart attack, and you have to do open surgery. This guy is not in the best physiological state. It's the third time he's going to go and open the chest. Doesn't look good. You want to minimize the amount of drug you give to this guy, but you don't want him to wake up or feel a ridiculous amount of pain during surgery. So if you have a way, and this is not the way yet, but if you have a way to predict how much drug you have to give this guy, then it's great. Because of course you target for lower, and then you'll see if the guy is sort of twitching, you give a bit more. But at least you don't start attacking immediately. So this is again single subject predictive brain activity. Okay? I'm going to skip the last one, so I go and have 1 minute of discussion about the summary. So effectively, again, the same guys, we gave them drug, and we could separate in the brain activity, this again, the ERPs, we could separate the amount of drug you got in blood. We measure blood, the concentration of the drug in the blood, because you might target for 0.6 nanograms per kilo of propofol, but what you actually get, some would get 0.3. He's a hardcore. I don't want the drug, and Stani will get 0.7. She will even get more than what you give her, because it's different personalities. And in that case, we can measure the amount of drug in blood, and then we can predict the amount of drug in blood by looking at the brain activity at the early peak of the EEG, which is yet again another novel result. Interesting. It's not predictive necessarily, but it's informative, because you can do this all the time during anesthesia, but you cannot keep on taking the drug, measuring the propofol, taking the drug, measuring the propofol. That takes several hours. While the EEG, you can do it online. Okay? And this is a slightly different one, but similar. It's the reaction times in the task they were doing while drowsy, while sedated. It had a relatively nice but mild correlation association with the P300, the other one. So we separated drug and capacity to respond. So I'm going to go to the summary and finish in 1 minute on top of the cross line. We're on the way to full data and continuous measures, and that's a good and a bad thing, all right? Because it's too much data. So we have to compress this in a way and learn what's important, or at least what we can predict is important. There's a lot of geeky aspects of this, but also there's a lot of conceptual effort to understand what the geeky measures can tell us and why we want those geeky measures. And most, the questions that were posed to the to the speaker just before were questions about integration of the projects. Yeah, how is this thing different from this in this wealth of complexity? Okay, so that's what we want. We want a lot of anthropology and philosophy and real cognitive psychology to inform the geekiness of the genome project, the brain project, etc. Otherwise, it's just going to be a ridiculous amount of data that nobody can interpret, and that this is going to tell us a lot in 10 years. Why it just doesn't tell us something now, if we think about it, what we want? EEG is direct, portable brain measure. Don't have to convince you of that. The EEG evoke potentials, time frequency analysis, or connectivity signals are easy to calculate online and very informative if you know what you're asking. This approach is beyond diagnosis and beyond prognosis and beyond treatment because it's about you, your identity, and part of your personality, and slightly more than that we can discuss. Thank you.
Thank you so much, Tristan, for the extremely animated and dynamic talk. Yes, one question. Sam gets the vote.
This is a fighter, man. He wouldn't go down with sedation. Thanks, Sam. Yeah.
Really interesting talk. So my question is, and so you had kind of this thing about kind of the order kind of in which information passes around. So this drowsiness thing, do you think of it as coming from somewhere, or do you think of it as chemical? You know, I was thinking, you know, there's all this stuff about, you know, pupil size fluctuations, you know, locus coeruleus kind of all kind of associated with kind of dynamic kind of reorganization of kind of brain structures. Do you think of it that way or something differently?
You mean in terms of this drowsiness for sedation or normal drowsiness in falling asleep or any kind of change in consciousness?
Either. I was most thinking about, you know, drowsiness falling asleep.
Yeah. So there is you know, years of understanding that in 30% of this room will be easy sleepers, and I could point out who they are. That were, you know, even if the talk is very interesting, you might get a bit drowsy or you will fall asleep in the train. So the natural variability between people about sleepiness or drowsiness or the capacity to change state or the capacity of arousal, it's something we know, you know, long ago. The question is how we can predict this and how we can prevent this to happen. So how we're thinking about it, there's some people looking into these simple measures like pupil diameter and etc. I prefer, in this case, the brain signature of the EEG while you're awake to predict the dynamics of transition, when you're going to get a bit drowsy, and when you're going to stop being able to integrate complex information, or even further down the line, integrate simple information. So this is the way I want to think about it. I want to think about it in terms of, you know, a dynamical system. And whether we use, you know, pupil size, diameter, or EEG, or heart rate variability, or any other, you know, eye tracking, etc., I don't mind. I think just the EEG is slightly more informative if we know how to measure it. But of course, it's more daunting because you have too much information compared to pupil diameter. It's slow and etc. But the way I want to think about it is about the variability between people and the complexity of the dynamics. So both things that we work on, and we know they're a pain, but we need to move from simple, you know, cognitive neuroscience to real, you know, life complexities.
Thank you for echoing our motto. One more big round of applause for Tristan.